Treatment Showcase series. In today's video, we are looking at eczema. Before we look into the treatment, the pathophysiology and the causes of eczema, what's going to be important is to clarify some definitions. I want to clarify dermatitis versus eczema. What is dermatitis? Dermatitis itself refers to the inflammation of the skin. Eczema, on the other hand, is a term that can be used to describe a group of conditions. And these conditions are marked by erythema, edema, vesiculation, dryness, scaling, lichenification, and fissuring. How do we actually classify the eczema itself? What can we do to classify this condition? Now, before we actually move into that, a brief point to mention is dermatitis and eczema are used interchangeably just to make matters a bit more confusing for you. So, we've got the classification. How are we going to do that? You can divide eczema depending on the stage it is in. Is it acute? Is it subacute? Is it chronic? So that refers to duration. And the presentation does change depending on which stage the eczema is in. We can also divide the eczema into endogenous cause or an exogenous cause. When we refer to an endogenous cause, that is referring to the body itself or hereditary. So this inflammatory process is caused by the body itself. The conditions involve atopic eczema, seborrheic dermatitis, stasis dermatitis, and so forth. We've also got the exogenous dermatitis, and this refers to a cause of the eczema because of external factors or the external environment, such as allergic or contact dermatitis. That being clear now, let's move on to eczema itself. So I want to bring your attention now to the cause or the pathophysiology of eczema itself. In order to understand this, what I've done is I've divided the epidermis into its various layers. The layers can be divided into the basement layer, which is the layer that all the other layers sit on. We have the stratum basale. The word stratum can be divided into strata, which means layers. We've got the stratum spinosum, we've got the stratum granulosum, stratum lucidum, and the stratum corneum. The epidermis primarily consists of the keratinocytes. Keratinocyte is a special cell that contains keratin, which is this special strong protein that gives it its structure. The structure relates to its function, which is where the epidermis acts as a barrier. What is important to note is the layers at the bottom, the stratum basale, stratum spinosum, are actually active layers because they're closest to the blood supply or the source of energy. As you start to migrate upwards, the cells die, lose their organelles, and are no longer living, and we call them corneocytes. So the stratum corneum or the stratum corneum actually consists of corneocytes, that is dead keratinocytes. So what actually does happen in eczema? What I've done is I've enlarged the stratum corneum and I've taken a cell. So we've got one cell here, which is a keratinocyte or a corneocyte because the keratinocyte is now dead. And what I've done, I've drawn out the structure. What we have keratin and we have this special protein known as filaggrin. What ends up happening is that the keratin itself is binded to another keratin via this special protein known as the filaggrin. And what happens in eczema is the filaggrin becomes defective. As a result, we have decrease in NMF, which is the natural moisturizing factor. We have an increase of the pH. We also have increase of water loss. This makes the upper layer of the skin become defective. It cannot act as a barrier and becomes leaky. And what is it leaky to? It's leaky to all the allergens that may present within the human body, such as pollen, dust mite, and so forth. They will then enter inside the skin, causing inflammation. And this inflammation causes an imbalance between Th2 cells and Th1 cells. We then get further inflammation, which causes further irritation to the skin. That causes further breakdown of the stratum corneum. And as a result, we have even more infiltration of allergens, and then you're in this vicious cycle of inflammation, allergens enter, irritation, and then you get eczema. So what are the clinical features of eczema? This really depends on the stage of eczema. If it's acute, initially you have these vesicles, So these blisters that are fluid filled, and they normally can cause itching and irritating. They burst, become encrusted, then you can get dryness, you can get itchiness, you can get lichenification, fissuring, and so forth. Obviously, as you're aware, the moment you start to break the layers of the skin, you can also get an infection. Initially, what happens is that this condition presents between the age of 3 to 12 months, normally affecting the head, neck, scalp. As you start to get older, so children start to get older, we also have the flexures become involved. That is the antecubital fossa, which is here, and behind the knees itself, the popliteal fossa, and I've drawn that illustration here. The differential diagnosis really varies depending on the stage of the eczema itself. If it's an acute eczema, when it's first starting off, you have these vesicles and this fluid, you may think actually impetigo or even an insect bite. But as it becomes chronic, it totally changes presentation. You have scaling, you have dryness, so you would need to think about possibly fungal infections. So how are we going to treat this eczema? The first thing is that we must repair the defective barrier. We have to moisturize that barrier. And you can do that by offering a patient an emollient. I prefer ointments. Again, I'll be doing a separate discussion on which emollients to be recommended and how to use them appropriately. You may also recommend the patient to actually have a bath in lukewarm water on the basis that they're using a soap substitute and they're using special bath oils, which can also further moisturize the skin. You may want to recommend an astringent, and this is normally used to dry up the exudate. As you start to become more competent in prescribing and offering treatment, you may want to consider, in some cases, topical steroids. Topical steroids do have a role to play within managing the eczema, and it's very important to be aware of which treatment to offer. I prefer to use for the face, normally hydrocortisone 1% ointment. Again, if you are going to prescribe, follow the guidelines and make sure you're competent in your prescribing. As I've mentioned previously, I will be doing a separate video talking about the in-depth treatment where we recommend emollients and what topical treatments and steroids to use. Immunomodulators have a role as well. You could also use antihistamines if the patient is not able to sleep at night and keeps itching. Again, be careful with the treatment, make sure it's appropriate for the patient. Treating of the infection, if there is an underlying infection, that would need to be treated. And it's not that straightforward between recommending an oral antibiotic versus a topical antibiotic, plus or minus a combined steroid, because topical treatments can cause contact dermatitis. You may also want to consider wrapping, where you wrap around the skin, which can cool and soothe the skin. I hope you found this video useful. Subscribe to my YouTube channel, follow me on LinkedIn. Thank you for watching.